The methodology of long leverage in the body is a concept and a technical application used by some of the manual therapy fields actively. Fascial stretch therapy, osteopathy come to mind, but as well many physical practices, whether that's yoga, tai chi, qigong, they as well use this concept. And they can use it without even knowing it at the time. And this is simply because it's inherent that, to an extent, the foot will have an effect on the knee, or even further up, that foot in a way can pull and make changes as high up as the pelvis or low back. And this is what we'll be talking about today under the concept of closed packing the hip. We're going to be talking about it in a different way, but still getting the same effect out of a different series of motions. Now, the concept of long leverage is often thought of as too powerful, dangerous even. And this can be true if it's utilized improperly, if the forces applied to the body are too excessive in that long leverage and it's applied too quickly and harshly. It can be very damaging to the tissues in between, ligament strain, muscular strain. This is truly dangerous because we are using mechanical principles, powerful mechanical principles, to gain an effect. However, should we do things properly, should we go slow, gently, and be aware of what's actually happening when we're using that long leverage, it is very safe. But it does take a fair amount of patience. So, what you have to understand, when we talk about long leverage, it is actually inherent in the body. The reason it can be used at all is because it's natural and it's normal. So let's say we're looking at a pelvis. From the top down, we're looking at a transverse plane cut. So this would be the ilia, that's a sacrum there, there's a pubic symphysis over here, some hips on either side, and the leg on one side pointed out, and the leg stepping back. So one side's going forward, one side's going backwards. And when we fully extend the hip, understand extension is going backwards. It's this one over here. It would be the equivalent of this hip going backwards like so. If it goes backwards like that, the ligaments in between the innominate and the femur go to full lengthening. They take up the slack in between, and that head of the femur is pressed into the acetabulum. So looking at it from this side, looking at it from our side view, a lateral view, there's a ligament that goes around here, ischiofemoral ligament. There's a ligament between the ilia and the femur, iliofemoral, pubofemoral ligaments. And these, with a full extension, are lengthened to the point where they resist further lengthening. So this area is quite tight, this area between the hip and the innominate and the femur is quite tight, meaning that there is no loss in movement between the two. These two are now intrinsically tied together. This is for a purpose. This is actually to make it so that when we are stepping, we pivot the foot quite naturally because the forces from that hip are transferred down to the leg. It's a shared movement at this point. And it's really largely because the whole pelvis is going forward. It's swinging around, the legs coming forward to step forward too. And technically, at this point, this is neat, but technically the pelvis is moving forward, but the hip joint is staying roughly in the same place. So we're getting a top-down action, a top-down long leverage from pelvis to leg. So this is natural, it's normal, it happens essentially anytime you take a bigger step. Even with a smaller step, it still happens. But importantly, it's happening constantly throughout the day. So it is there whether you like it or not. You can argue against it, I guess, if you wanted to, but that would be pretty pointless. What we're going to talk about now is actually getting the same effect in a different way. So I'm going to take that away now. So we're going to get the same effect in a different way. And that will give us ability to move the body in a safe and gentle way that is both low impact on the user of the leverage and as well the patient. So let's say we are holding a foot. We're just holding that foot and we've got two hands, one hand here and one hand here, and we decide to internally rotate that foot. So we're going to start off real simple. That foot gets internally rotated, and of course, because it's directly attached through that ankle joint here, it's going to pull on the tibial. It's going to turn that tibia as well. And so this starts picking up slack. It starts taking up slack, I should say. And that will be transferred just on a very basic level. We're going to start very basic first. The MCL, cruciate ligamentous ACL, PCL, and even the MCL are tightened up, or at least they're lengthened to the point where they start resisting further lengthening. And so that means, just like we made the example of the hip, these structures, tib and femur, and even the fibula to some extent, because that, of course, has our LCL there. Even the femur, tibia, fibula, they're all tied together now. As we move that foot, as we move the tibia, the fibula, now we start to move that femur. And so we start to bring that femur into an internal rotation too. It's transferring down the leg. This is normal. It's happening. It's in the reverse order we would normally do it, but that's fine. It will still take the same effect. As that femur now internally rotates, we start to further lengthen the ligaments in the area. So this iliofemoral and the pubofemoral can lengthen too. And as well, in a big way, and I'd say in a more significant way, the ischiofemoral, because it wraps around to the front as it internally rotates, will tighten that hip. And so we get the same effect, similar effect anyways, not exactly the same, similar effect as when we extend the hip. The ligaments have lost some of their slack, and so that means between the innominate and the hip, we are pushing them together through tension in an odd way, but it still works. So that means when we move the foot down here, we move the innominate as well, or at least we move all the way up to the femur. And this is significant because not only can we use the body, we can use one appendage to move the other, we can move it at a greater distance, and it's a much longer axis than we would normally have without directly touching it, which is cool. Now, it gets more complicated than that. Now, that's a very simple way of looking at it. There's actually a lot more tissues involved than you would think. So, take for instance the gastroc muscle. As we internally rotate that leg, because the gastroc muscle goes from femur, basically the lower end of that femur, superior to the condyles generally, and into the calcaneus. As we internally rotate that leg, it tends to lengthen that tissue a bit. So it's now pulling on the femur. So that's certainly one tissue that goes between those two structures. Of course, that gastroc will have multiple bands. As well, working our way up, as the femur starts to internally rotate, we also get the adductors pulling on the pubis bone. There's three of those. There's a magnus, a longus, and a brevis, and they should all lengthen significantly too. They are attached to the linea aspera in the back of that leg, in the back of the femur. And so as that rotates posteriorly, as the linea aspera basically goes that way, the distance between the pubis and the linea aspera change. So again, we're pulling now on that innominate through those adductor muscles. Another big one we could mention as we start to build around this structure, start to build around the whole innominate, is from ASIS, maybe you've heard of it, rectus femoris. ASIS all the way to the patella, and really through the patella, that's not looking too bad, through the patella into the tibia, through a shared tendon. The vastus complex could be talked about too, but just for clarity's sake, we're going to leave that out. So now we've got more on the front side. As we internally rotate that leg, again, as that comes in, we're going to see that rectus femoris lengthen, and so we should see that it changes. Furthermore, we can start to look on the lateral side of the hip. So looking over here, we'd have some gluteal lines, of course, but we have a gluteus medius, gluteus minimus. The minimus, that would, of course, be in behind, but we've also got a TFL muscle, tensor fasciae latae, with a descending band, the IT band, coming down. So we can take these guys, they'd be here, not as visible, but we can take these, and they come into the femur, from innominate to femur, and then they come down to the outside of the tibia through that IT band. So as we internally rotate that leg, as this leg's going this way again, you can see that those muscles are also lengthened, even the fascias in between. This is without mentioning the major fascias in the area. And so we've started to grab up at different points of that innominate. Again, through the lateral side, through the front, through the pubis area, all of that's been grabbed up. Now let's say, for instance, we added just a little extra element to this. We just added a little extra element. I'm going to take that away for just a second. And we added a slight flexion to the hip. I've got all these points of access, rectus femoris again. We've got the adductor muscles. We've got the gluteal muscles. So that's pulling like that, pulling like that, pulling like that. What if we added a little bit of flexion? We suddenly engage the hamstrings through the ischial tuberosity, because those hamstrings are coming from somewhere back in here and attaching all the way down past the knee. So that's a big deal. It means that we can pull essentially from all sides just by internally rotating that foot, transferring all the way down the leg and taking up the slack between all those tissues. This is just a basic way of engaging what we call long leverage. It's grabbing up that innominate. It's grabbing up that big hip bone, which isn't a real term, I know, but big hip bone for those uninitiated. And so it makes it so that in conjunction with all the other ones, we start to have a greater control over this structure at a distance. But we can go a lot further than that. This is good, but we can actually take this up quite a bit further than that. Because I should, therefore, if I can move the innominate from the foot, I should be able to move sacroiliac joint, pubic symphysis, which is a moving joint, and then through even some other attachments, whether we're looking at like the erector spinae, which are essentially fibred like that, or the quadratus lumborum, the QL muscle, which is essentially fibred like that, we start to have access higher and higher up in the body. Those erector muscles go fairly high. That QL goes up at least into rib 12. And so as we change the foot, as we gain access, better and better access, as the foot moves, so too should the higher up structures, without really having to think about it. This is very much possible. It's very reasonable because it's already happening in the body fairly often. You could very well take that leverage up higher with greater and greater skill. You could exert a force all the way up potentially into the head if you wanted to. The fascia does connect all the way up there. And so it's possible, though you would have to be very, very precise to do it with any reasonable skill. So that being said, the way we learn to do this, one really simple way to do is just simply to test gradually. If you want to be able of just taking that foot and moving it in such a way that it starts to affect higher and higher structures all the way up, you can do it slowly and approach it very gently. So if you just slightly internally rotate that, you can take it all the way if you wanted to right away, but if you just start by slightly, gradually, internally rotating that foot and just pulling and pushing very gently and feeling and watching as you do so how the lumbar spine and how that pelvis changes more and more, how that pull and push is exerted more and more into that pelvis and into that lumbar spine as the movement all the way down here starts to show up down here visually and in a palpatory way. You can start to gain access at a greater distance, and that's the point of long leverage. It can be very powerful, but at the same time, very useful. Now, the reasons we do this, the reasons why this is of use at all, is a very easy concept to understand, and I've summarized it here. And what it comes down to is that we can use long leverage because it's powerful, but with minimal effort to use. We don't have to try very hard to get a big effect. And this is good for the person doing the long leverage, creating long leverage, the therapist. But as well, at the same time, it's natural and well received in that it won't be a lot of stress on the patient, the client, and it won't be irritating in any ways. There are certainly cases where short leverage is needed. Sometimes you just need to push on things, and that's the helpful thing at the time. But if that's not the case, if you can do it with a long leverage, the body is wired. It's neurologically wired to receive that long leverage as natural and normal. And so it's probably going to have a lot easier of a time accepting the change and then sustaining that change over a long period of time. This has been Simple Lines Anatomy. Hopefully you enjoyed that.